Thanks very much for the introduction, Professor Scaglioti. Thank you very much, Peter, for the invitation to come to Prague. Wonderful city. I hope to enjoy it later. So I'm going to give you an overview, I hope, of what's been happening in endobronchial techniques. It's a massive subject, so I'm trying to tailor it to the sort of spectrum of problems we can help deal with. Clearly, bronchoscopy has been around now for about 130 years, and hopefully nobody in this room remembers this first chap on the left who was doing this under totally awake conditions without any sedation or anesthesia. You can see somebody holding the head there to stop them from wriggling. Quite an unpleasant experience, perhaps. But nowadays, bronchoscopy has evolved enormously, and you could do quite complex procedures under conscious sedation, quite comfortably, quite safely. Of course, the difficulty with bronchoscopy and some of the sampling techniques we have is that we're giving you smaller and smaller samples to work on. And I'm sure the pathologists over the next few days will highlight some of those challenges. But so far as to say, these techniques still accommodate the modern agenda. In the most recent years, technology has advanced so that we have different imaging modalities through the bronchoscope. We obviously have endobronchial ultrasound, which you'll all be fairly familiar with some forms of that. And of course, latterly, some technologies around navigational bronchoscopy. So can these techniques optimize diagnosis? Well, I would very much hope so. Stood here as somebody who uses these things on a daily basis. Clearly, if you look at the way we're supposed to use these technologies, NICE in the UK very much says we should use a single invasive test to provide the most information on stage and pathology, and I think these techniques do that. The staging principles for the ISLC, these technologies very much can support. They provide a pathological diagnosis. We can give these group stagings, even the more complicated 8th edition. And I certainly think we can give the patient the benefit of the doubt where we've evaluated them as fully as we can. Clearly we can stage very well, and that clearly dictates treatment and prognosis. But I think one of the key things is that we can do these tests repeatedly in the comorbid, in the elderly, very safely with minimal risk. So that really does extend the opportunity to provide radical and, to some extent, palliative treatments to all categories of patients we see. The challenges, obviously, are around sample size, quality, and type. But in an engaged world where we're trying to work very closely with pathology and medical oncology, these are not insurmountable, as I've said. White light bronchoscopy is the standard. It's been around, as I say, for a very long time. But of course, it's very limited in some ways. We can't really see much beyond the 4th generation bronchi. Limited perhaps in seeing some subtle abnormalities. And of course, seeing outside of the bronchial tree has been very difficult. You can extend it with some blind sampling to some extent, get based on CT, but a little bit more difficult. So a lot of the evolution has been on addressing those limitations. And so what I've just suggested here, as I said before, there are advances in imaging, so autofluorescence bronchoscopy, narrowband, there's optical coherence tomography, and confocal microscopy. The latter three there are perhaps not widely used as much as autofluorescence is in big cancer centres at least. So I'm going to focus my comments on autofluorescence here. Endobronchial ultrasound I will touch on and spend a bit of time on navigation. Autofluorescence is very helpful. We use it a lot. I probably do over 400 procedures a year. The principles are fairly straightforward in that we're lucky that abnormal tissues have very different spectral characteristics to normal tissue, and the bronchoscopes and the technology and the chips within them allow us to display that in real time on a monitor. So pre-invasive disease, subtle invasive changes, the edge around tumours, can be seen much more readily. There are 2 meta-analyses now that have looked at a number of autofluorescent systems from a large number of manufacturers, and you can see that the detection of abnormalities is about 2 to 4-fold more sensitive, perhaps a little less specific, so you do biopsy a few more chronic inflammatory abnormalities than purely malignant. So here you can see a plot of the sensitivity is very good, specificity perhaps not so, but I do find it a useful technology to have. So its current uses are fairly broad. We can use it to evaluate people with suspected lung cancer, help us to target our biopsies to the right areas. It can be useful for staging. We've talked about T2, and within 2 centimeters of the carina, that can be quite useful in selected patients. Detection of synchronous disease at the time of evaluating somebody with suspected lung cancer already. So you can pick up more subtle lesions in the contralateral lung, which may affect your treatment planning. And in people with previous lung cancers, we find it quite useful, particularly in the squamous cell population, whether that's been head and neck or in lung, to pick up second malignancies and to assess surgical margins. Perhaps, certainly in my part of the world, we don't do a lot of sputum testing nowadays for atypia, but if you see people with high-grade changes in sputum, you can use autofluorescence to evaluate them much more accurately. And of course, if you incidentally biopsy something which is severe dysplasia or carcinoma in situ, you can use autofluorescence to follow these patients up very accurately too. So what about beyond the bronchi? Klaus has already talked a little bit about imaging, and whilst I am very keen to have as much state-of-the-art imaging in the department as we can, I think when it comes to staging the mediastinum, we know that CT and PET are not optimal. Okay, so you need to have positive likelihood ratios above 10 to be clinically useful. So a big node on CT scanning or a hot node on PET scanning is not sufficient where you're trying to stage people for curative treatments. Negative ratio less than 0.1 is also considered appropriate. So perhaps negative PET scannings are more useful than positive ones in the mediastinum, different entirely for nodules. So really there's no node size that predicts malignancy on CT. And as I say, PET positivity does need to be clarified. And there's a very good article in the ACCP guidance from 2013 which goes through this in some excellent detail. Of course, for a number of years, many chest physicians have used blind tBNA. It's a very useful technique. It's very cheap. It doesn't require the expense of EBUS, and you certainly don't need it for these types of CT scans. So in people with large mediastinal volumes of disease, blind tBNA can be very useful. 4 out of 5 cases you'll get an answer. So it's very good for ruling in the diagnosis. It's not very good for ruling out the diagnosis. So where you've got low volume mediastinal abnormalities, a negative blind tBNA is not terribly helpful, and you do need to do more sampling. And that's really where linear EBUS tBNA comes in. You'll all be very familiar with this, so I'm not going to spend too much time on this technique because it's fairly widespread today. But clearly, it does allow us to sample a lot of mediastinal and hilar nodes, and that may be relevant with the 8th edition coming. It allows us to sample central tumours around the major airways. It allows us to sample any PET-positive nodes, and it can be very useful for restaging too. Clearly, it accommodates the modern agenda of repeated biopsies with different lines of treatment, confirming recurrent disease, particularly after radiotherapy, where there can be a number of other infective and inflammatory abnormalities. And outside of lung cancer, of course, it can be useful in other malignancies that have spread to the thorax. The little graphic on the right-hand side here just really tries to reflect, this is a series of cases where you can demonstrate very well that regardless of age, the tolerance of this procedure, which can be up to about 40 minutes or so, is exceedingly good. In fact, better tolerated in the elderly than in people under the age of 70. That's a conscious sedation series. I don't think there are any real controversies with EBUS TBNA. The meta-analyses of its utility are there on the left, but it's important to recognize that it does differ depending on what your prevalence of disease is in the population you're sampling. So I think it's one thing for all chest physicians in all parts of the world to go out and buy this equipment, but are you truly delivering it to the expert standards that are set out in these documents, and of course where these authors are doing this in large volumes on a daily basis? So I think if you are providing this service, you really should go out of your way to demonstrate exactly what it is you're providing, because I think it does matter in terms of the day-to-day management of your patients and indeed who you're going to send for selective surgical sampling to confirm your results. On the right here, just some data from our part of the world. So we've got 3 centres here that are performing EBUS TBNA for a catchment of about 3.2 million. This is the cardiothoracic centre. These are 2 smaller centres. And just as a snapshot, you can see that the prevalence of disease, these are 2 audit periods over a 3-year period, they differ quite a lot. So patient selection in these centres is very different. You can argue in this centre, perhaps you're sampling a lot of advanced stage, big nodes with EBUS, which, as I say, is not really what the technology is about. And of course, your appropriate sensitivity and negative predictive value will differ enormously. And if you've got a negative predictive value on your EBUS sampling of 60%, you probably should be sending a great number more people for mediastinoscopy before you're considering a thoracotomy. Peripheral sampling of invisible disease is increasing, actually. We spend a lot of time doing this now, mainly with these fairly cheap form of navigational bronchoscopy to some extent, using the radial mini probe. This 1.7 millimeters goes down a standard bronchoscope, and it's very good for, so on CT scans sometimes you can see an abnormality and think, oh, that's going to be quite easy to get to. And then as soon as you get down there, you've got 7 segments you want to try and find which one leads to that area, and it can be quite difficult. So this is a very useful technique to select the appropriate segment, make sure the chances of getting appropriate tissue are high, and you're minimizing the risk of pneumothorax. The other probe is probably less used. We don't do this a lot, but we do have it. This allows us to do staging more than sampling peripherally, so it's more for a central airways assessment. So for the depth of invasion of what are thought to be pre-malignant lesions, to ascertain whether you're giving local treatment such as brachytherapy or external beam if there's cartilaginous destruction, or indeed to see if there's any tracheal invasion from tumours that lie close to the central airways, or indeed sometimes esophageal tumours invading into the trachea. So fluoroscopy-guided transbronchial lung biopsies, or perhaps even blind transbronchial lung biopsies, the sensitivity of those techniques is relatively limited. But using this mini probe, you can certainly improve that highly significantly, particularly in sort of about nearly 80% from around about 60%. Negative predictive value is not good, so again, just because you don't get tumour doesn't mean you can rely on that. You need to go and sample in a different way if it's relevant for you. The beauty of this technique probably is that in small samples, 2 or 3 centimetre samples, tumour sizes, your success of biopsying with these techniques is much greater. And this is just a graphic just to illustrate, small tumour, close to the bronchial tree, but not quite sure if your bronchi are getting there. You can pass the probe down selective segments, see these pictures, and then if you've got a nice circumferential ultrasound image, the chances of getting a representative biopsy for this are very high, up in the 90s, and with minimal chance of a pneumothorax. So it's particularly useful for people with limited lung function. You've seen some pictures, I think Klaus showed, with horrible emphysema, and so this is a very good technique for getting tissue from people who might be considered unfit for surgery, but could have access to stereotactic radiotherapy, for example, and obviously providing tissue for the molecular agenda. We've certainly used this quite a bit in people with brain metastases and a small primary, such as this, just to ensure that we do our best broadly. And you can add you can put guide sheath placements in, so leave a guide sheath behind and put small biopsy forceps down. So it's very useful. I talked a little bit about airway invasion. I've only got one slide on this, I think, but it's quite a niche area. I think we probably ought to do a lot more of this to be expert at it. This is just to highlight, actually, one case using it, that this was an early stage squamous carcinoma that was resected by the surgeons, but they'd failed to appreciate at a different centre there was this area of abnormality at the entrance to the right upper lobe, which on autofluorescence you can see is much more pronounced. This was squamous carcinoma in situ, so she had a positive margin at resection. So we followed this for a while and then assessed it, and you can see the cartilage layer here is completely gone. So this lady had external beam radiotherapy rather than brachytherapy as we were planning. Navigational bronchoscopy, there are broadly two forms of this. One's quite expensive on disposables. Electromagnetic navigational bronchoscopy is quite appealing. I've never done any of this, largely because my centre won't allow me to buy it. But essentially it runs off the principle of GPS satellite technology, a steerable catheter that you pass down the bronchoscope. It requires a lot of upfront image processing, outlining your targets, plotting a course. But of course it has both diagnostic and therapeutic applications, because sometimes after you've biopsied the tumour you could go on and provide microwave ablation at the same sitting, or you can put in fiducial markers for stereotactic radiotherapy. But the ACCP do recommend that it can be very useful if abnormalities are difficult to reach with conventional bronchoscopy. A fairly good diagnostic yield of about 75%, again for small lesions. Virtual navigational bronchoscopy is really using high-resolution CT and reconstruction, again to try and outline a path to an abnormality, perhaps best used with an ultra-thin bronchoscope that allows you to get down to maybe 9th generation bronchi. You can see here these are a selection of studies that are perhaps lesions up to 3 centimetres in size with a diagnostic yield of around about 75-80%, and around about 70% or so for lesions less than 2 centimetres. I think what's quite striking here is the complication rate is negligible, and quite often in CT published series the complication rate from CT is around about 20-25%, so it provides a much less hazardous result. Obviously the title of my talk included therapy, and there aren't any major advances in therapy. A lot of these technologies have been around for a long time. I guess the advances will be the ability to apply these therapies down the peripheral sampling modalities. There's very good overviews of endobronchial therapy in the BTS guidance from about 5 years ago, in the ACCP and the ERS. These therapies can be both curative and palliative, and I think they're often overlooked in a curative sense, and can be very good at relieving distressing stridor, and certainly provide patients with a much more comfortable death with minimal interventions, really. We can do them under general anaesthetic or conscious sedation, but it does require a good MDT approach, like all high-quality oncology, and you have to consider in the various modalities available what you're trying to achieve, how quickly you need to achieve it, and what the obstruction is in terms of purely within the airway, outside, or a combination of both. And there are mechanical, thermal, and biologic treatments to choose from, and you can use single or multiple depending on, say, what you're trying to achieve. So these technologies, I think, do help us span the spectrum of disease, from screening through preneoplasia, for people with peripheral disease, central disease, and metastatic disease, and obviously have a role in the follow-up of patients after definitive treatment. In the diagnostic sense, I think navigational bronchoscopy should help as screening programs become quite established to help keep the thoracotomy rate low for small peripheral nodules. And in a therapeutic sense, these things are still evolving, and I would hope are of use to many. It would be difficult to speak to an audience without suggesting that the samples we provide, whilst tiny, can accommodate the molecular oncology agenda. I don't think you have to be a little bit more aggressive and provide a little bit more tissue than perhaps we did 10 years ago. But if you know what you're doing the procedure for, you can certainly make sure that you have adequate material for IHC, for molecular path. Perhaps the challenge at the moment is whether we'll be able to provide you with the right amount of material for immunotherapy testing, due to the way the companies want to type that and the exclusion of cytology samples, which I don't really see any sense in, but that's perhaps the most controversial thing of this talk. In terms of the conclusions, well, as I say, I think the endobronchial therapies are very useful. They will continue to evolve, and there are some very interesting things at the major respiratory conferences with a new Archimedes system, which is will be very challenging, and I'm sure will put my blood pressure up. They're very safe, they're very effective, and they do accommodate the aging comorbid population very well. We can apply it very broadly across the agenda, and I would really encourage all respiratory physicians who have an interest to try and be as dedicated to lung cancer as possible so that we are reproducing the sort of results we're seeing in all the expert guidance. Thank you very much for your time.